Hello class, we're going to continue with the concept of stress and coping and with our exemplar of mini mental state exam. I did give you a copy the other day of a more revised version of the mini mental state exam, and we did talk a little bit about this in Nursing 100, and just to kind of refresh your memory, we give this exam to some of our patients who might have some type of cognitive impairment that's really no longer considered to be normal or even part of the aging process. We know that the older adult is at much higher risk than the rest of the populations for changes in their cognitive function, but we just need to know exactly where they are on that scale to determine if we need to take aggressive action in how far along their cognitive ability has declined. In the older patients, cognitive function is especially likely to decline during illness or injury, and that's probably a great time for us to really hone in and have a good sense and a good awareness whether or not their cognitive ability is declining. And our assessment of an older adult's cognitive status is instrumental in identifying early changes in those physiological status, their ability to learn, and really how they're responding to treatment. So it's our role in being an advocate for our patients to really evaluate those responses to their treatments. And we find that with the mini mental state exam, it's a tool that can be used to systematically and thoroughly assess mental status. Remember, it's an 11-question measure that tests 5 areas of cognitive function: orientation, registration, attention, calculation, recall, and language. The maximum score is 30, and a score of 23 or lower is indicative of some kind of cognitive impairment. And the MMSE takes only about 5 to 10 minutes to administer and is therefore practical to use, often, repeatedly, and routinely. And anytime you ever feel that there is some kind of change in their cognitive thinking and ability. And it is effective as a screening tool for cognitive impairment with the elderly, even for people in community dwellings, hospitalized patients, and even our adults that are institutionalized. An assessment of an older adult's cognitive function is best achieved when it is done routinely, systematically, and thoroughly. It's been around since 1975, and it has been validated and extensively used in both clinical practice and research. But just remember, with anything, there are strengths and weaknesses, and this tool is effective as a screening instrument to separate patients with cognitive impairment from those that do not have any. So in addition, when using this instrument, it is able to measure changes in cognitive status that may benefit from interventions. But remember, the tool is not able to diagnose the case for changes in cognitive function and should not replace a complete clinical assessment of mental status. And as you are probably quite familiar with, the instrument does rely heavily on verbal responses and on reading and writing. So therefore, if our patients are hearing and visually impaired, or even if they have like an endotube or have a low English literacy, or those with other communication disorders that kind of demonstrate that they're performing poorly, they still might be cognitively intact. So just remember that. So just sort of wanted to give you a little background on that. And with this said, I've got this PowerPoint up here on the screen in regards to cognition, just to kind of go over cognition and just what it entails, especially when we're talking about the elderly population. We know cognition is basically that mental action or process of acquiring knowledge and understanding through thought, expression, and senses. And as you can see, bring this PowerPoint down. It is a complex set of mental activities that we acquire, we process, we store, retrieve, and we use information. And this is just the parts and structures of the brain, more of a physiology review, where we can kind of remember and determine what part of what structure is responsible for what part of our brain function. If you remember, our hippocampus is responsible for forming new memories. And hopefully you were able to view the little video that was, there was a link in your course schedule that you kind of saw how the brain functions with the neurons and the neurotransmitters and the synapses, and just looking like, picturing it as little roadways that kind of connect, leading to the many thought processes that we have, including things like short-term memory, long-term memory, and such and such. Sorry, I hit something. These are just some theories of cognitive development. Piaget's theory, especially with children, talking about sensory motor, pre-operational, concrete operational, and formal operational. This is a theory that talks about the nature and development of human intelligence, involving 4 distinct stages: birth to 2 to 7 years of age, 7 to 11 years of age, adolescence, then to adulthood. Okay, and then we have Vygotsky's theory: children learn through their culture and through social actions with other people. Kind of relating to the fact that the development of a child is very much responsible of how they engage socially, in their ways in which they kind of interact with other children and even adults. And then, of course, the information processing theory, where the mind is continuously evolving, a computational system that takes in information, operates on it, and converts it into answers. We look at genetic considerations and non-modifiable risk factors, and look at cognitive skills that really do become increasingly complex, advancing from childhood to adulthood, and that makes logical sense. It's just what happens as we progress into adulthood. Changes in cognition experienced by older adults, some of it is normal part of aging. Some alterations sometimes develop, but always remember things like dementia and Alzheimer is not normal and is not part of the aging process. Those are pathologies that unfortunately happen as people begin to age. Perception, ability to interpret the environment, can be affected by impaired senses, definitely. And we know our elderly population really do have some alterations in their senses. Cognitive ability is often an information processing speed begins to decrease with age. You might tell an elderly patient something, but in order for that to process, it might have to be discussed with the patient again, repeated, and maybe only certain parts and pieces need to be given at certain times because of just the manner in which they're able to process that information. Impairment that interferes with normal life is not part of the normal aging process. And then our memory. With the elderly, short-term memory changes very little, but with long-term memory, we may see a more noticeable decline. And with learning, it may need additional time, just like I said before. And of course, motivation is important. Sometimes the elderly, depending on their life situation, may not always be very receptive to what you're teaching them about why they're in the hospital, or maybe teaching them about maybe a new diagnosis that has been given to them. If maybe they're alone and they feel like, oh, here I go again with another health problem, maybe they feel like it's just too much to handle, or they feel like I'm all alone, and there's really no motivation to keep me from understanding and better manage my illness or chronic disease that I've just been diagnosed with. Normal healthy aging is usually not characterized by cognitive or mental disorders. There should be no significant memory impairment. Their mental health and cognition should be essentially stable with just basically normal age-related changes, and should also have methods for coping with age-related changes. So just a little review on that when we're talking about cognition. And as we talked about cognition, we're going to just go over this PowerPoint fairly quickly. It had to do with your exemplars of eye disorders, namely cataracts, glaucoma, and age-related macular degeneration. And this PowerPoint is pretty much in depth, but it does cover a lot of the main ideas and important facts related to those particular eye disorders. Trying to get the PowerPoint to switch. These are some of the objectives when we talk about learning outcomes from these particular exemplars. The most common diseases of the eyes are cataracts, glaucoma, and age-related macular degeneration. First of all, when we talk about cataracts, let's think about what structure we're referring to that is definitely altered or impaired, and it's the lens. There is an opacification of the lens of the eye. The process begins at periphery of the lens, gradually spreads to the center, and because of that protein that tends to degenerate, it makes the lens very cloudy, which then interferes with light transmission to the retina and inability to perceive those images. It is very much a result of the aging process, and about 50% of individuals aged 65 to 74 will develop cataracts, and 70% of those older than 75 will also get cataracts as well. There's 4 types that occur independently of the aging process, and the first one is secondary, and that may form after surgery to treat another eye disorder or effects of medication or another primary disorder. Maybe the person is on long-term steroid therapy. Maybe they had glaucoma, had to have some surgery due to that. But that's what secondary cataracts are about. Then we have traumatic, which results from an injury to the eye. And then we have radiation. And this is common for people that work in areas that have a lot of radiation, like the cardiac cath lab, in special procedure, even x-ray techs who are around a lot of radiation, who take x-rays, sonography, things like that. Not necessarily sonography, but people that work with radiation. It's just long-term exposure to radiation. That's why it's important, if you're going to work in these areas long-term, that you definitely use lead glasses to protect your eyes from the radiation, thus reducing your chances of getting cataracts. And then congenital is might be a child who was actually born with cataracts, or maybe the development of cataracts in childhood. These are some of the risk factors too, obviously, as you age, and genetics, environmental and lifestyle factors. If you're one that's out in the sun, maybe people more in the south who see more sun than obviously we do in Ohio, without wearing good protection on their eyes, like good sunglasses with UV protection. People who smoke cigarettes, and obviously people who drink heavy alcohol consumption. Also eye trauma, diabetes mellitus, and of course some medications. Prevention, there's really no known methods, just obviously looking at the risk factors and asking yourself as you age, do I fall in that? Obviously you can't do anything about the aging process, but you can do things about lifestyle changes. Not smoking, refraining from heavy alcohol consumption, and definitely protecting your eyes from UV B rays, and making sure that there's your diet with sufficient vitamin C and E, and lutein and zeaxanthin. Then our next eye disorder is glaucoma. Primary glaucoma is no identified cause. And when we talk about glaucoma, they pretty much call it, according to your book, the silent thief of vision. The patient may typically experience no manifestations other than narrowing of the visual field, which occurs so gradually that it often goes unnoticed until late in the disease process. We look at the different types of glaucoma. Primary glaucoma, as I said before, no identified cause, and then there's two other kind: open angle glaucoma, chronic, gradually progressive loss of vision. This one is the most common form in adults. Okay. And what happens with that is it has to do with that flow of the fluid, the aqueous humor, through the meshwork into those various tiny canals within the eyes. And what eventually happens is the meshwork starts to change, which inhibits the outflow of that aqueous humor, and that's where your intraocular pressure starts to build up. And so the results from that are neuronal ischemia and optic nerve degeneration, leading someone to eventually lose their vision. And this type of glaucoma, open angle, tends to be a chronic and a gradually progressive disease. And it will affect both eyes, although the pressures and progression may not be symmetrical, may kind of be different with each eye. And open angle glaucoma is the most common form as adults, as I said, accounting for about 90% of all the glaucomas that are diagnosed. And it is more frequently in Latinos and African Americans than in Caucasians. Okay, and that's kind of some of the data that is concerning glaucoma. And then we have the angle closure glaucoma, and this is where those anterior chamber angles occur because the corneas start to flatten out or bulge. There's bulging of the irises into the anterior chamber. And then what happens is closure of that angle blocks that outflow of the aqueous humor through the definite areas of meshwork. And then, of course, that's where intraocular pressure starts to rise because there's an obstruction. And the increase in that intraocular pressure starts to damage the neurons of the retina and the optic nerve, and this leads to a very rapid and permanent loss of vision if it's not treated promptly. So that's kind of the difference between the two types of glaucoma. And the risk factors are: it's a leading cause of blindness worldwide. Again, aging, race, family history, people that use long-term steroids, and of course eye trauma. They get secondary glaucoma years later due to the injury that the eye has suffered. Prevention. There are prescription eye drops for individuals at high risk. Obviously, regular eye exams at least once a year, maybe even more often than that, depending on the pressures they find when they assess the eyes. Exercise, low intraocular pressure. Some types may increase intraocular pressure, and that might be something like yoga, where the head is lower than the heart, which could put extra pressure in on the head and the face area. Healthy diet, high in vitamins, carotenoids, zinc, omega-3 fatty acids. Again, prevent overexposure of sunlight and refrain from smoking. And the last one I'm going to talk about is age-related macular degeneration, which is the area involved with this is the retina, which will lead to problems with the optic nerve. And there is a degeneration of macular area of the retina, and there's two types. There's the dry and the wet. The dry is called the non-exudative age-related macular degeneration, and what happens is there's a gradual accumulation of these deposits called drusins, and pigment and epithelium detaches in small areas, and those areas become atrophic, and vision loss, typically not significant because it's a disease that progresses slowly and risk that the disorder will progress to exudate stages. The exudate is also called the wet age-related macular degeneration, and what happens is you've got vascular endothelial growth factor, causes growth of these abnormal blood vessels, and these are very unhealthy blood vessels that are very the integrity of them is very poor and weak, and what happens is they tend to leak and bleed, and this bleeding will affect that acute vision, and this is what leads to eventually severe vision loss, and it is the cause for legal blindness in the American elderly American older than 65 years of age. Okay. This form only accounts for about 10% of all cases of age-related macular degeneration. About 15 million people in this country have age-related macular degeneration, with 200,000 new cases being diagnosed every year. And it is the #1 cause of severe vision loss, and as I said before, and legal blindness over patients ages 60 or over. What are the risk factors? The most significant risk factor for developing age-related macular degeneration is aging. Other non-modifiable risk factors include race, eye color, and family history. Okay, it's seen more frequently, obviously, in women, unfortunately, because women tend to live longer. And modifiable risk factors include smoking, obesity, poor cardiovascular health, and excessive UV exposure. More than 20 grams of alcohol per day is associated with a higher risk of developing age-related macular degeneration. So, it's recommended, obviously, when anyone has a diagnosis of cardiovascular disease, that managing that chronic disease will definitely reduce your risk of developing AMD. These are some of the manifestations that a patient may experience when they might be, getting cataracts. The big thing is there's a problem with glare, affects ability to adjust between light, dark environments. Tends to be bilaterally unless there's a related eye trauma. And one cataract generally matures more rapidly than the other. And with glaucoma in the open angle, often there's no symptoms, and sometimes you see blank spots start to appear in visual fields. And then angle closure can cause intermittent pain, and also they have photophobia, which is very sensitive to light. And with acute angle closure, they have severe eye and face pain, and that also might be accompanied by general malaise, nausea, and vomiting, and there's an abrupt decrease in visual acuity. And with AMD, blurred vision, blind or blurry spots in central vision field, colors are less bright, and difficulty adjusting from bright light to lower light situation, and may have difficulty recognizing faces, and has to rely more on your periphery vision than central, because this is what it's going to affect. So we collaborate with our ophthalmologist, occupational therapy, orientation mobility specialist, low vision therapist, social worker, vision rehab program. And these are some of the diagnostic tests, obviously with cataracts. Know a little bit about your eye history using our Snellen and Rosenbaum charts. Remember, the Snelling is the distance eye exams and Rosenbaum is the close one. Might do a dilated eye exam. And these are the various testing they do with glaucoma: tonometry, fundoscopy, gonioscopy, and visual field testing. And these are with AMD visual and retinal exams, Amsler grid, wet, same symptoms as dry and visual distortions, obviously pupillary dilatation, fluorescein angiogram, and optical coherence tomography. With cataracts, there's really no meds to give. Maybe topically a beta-adrenergic blocking agent, prostaglandin analog, alpha-adrenergic agonist, and carbonic anhydrase inhibitors, and AMD angiogenic inhibitors. I'm not going to get into this because we won't ask you any questions about pharma on the nursing course on the final with these eye disorders. Obviously with cataracts, surgery is the only treatment indicated when your vision or activities of daily living are effective. Typically outpatient using local anesthesia, and the procedure is most common done is the extracapsular extraction. And after a lens removed, you can have intraocular lens implanted to restore binocular vision depth perception. Usually do one eye at a time, and 10 to 50% of patients may develop opacification 3 to 5 years after surgery. Vision can be restored by another procedure. Glaucoma, improve the drainage of the aqueous humor to prevent that increased intraocular pressure, and they may do a laser trabeculoplasty and a trabeculectomy, filtration surgery. If they're not effective, they'll do argon laser or cyclochrotherapy. And with angle closure glaucoma, gonioplasty, a laser iridotomy, and a peripheral iridectomy. That has to do with the iris, that part of the eye. And with your wet AMD, laser surgery, photodynamic therapy, surgical procedures do not cure, but they actually slow the rate of vision loss, and surgical treatment less common since introduction of anti-angiogenic drug therapy. And like I said before, there's no meds available, but what they'll do too after cataracts, they will prescribe an eye drop post-op, like a steroid to keep the inflammation down, and also an antibiotic to prevent infection. Glaucoma relaxation, regular physical exercise, low intraocular pressure, and angle closure glaucoma not responsive to exercise. These are things without using medication, what we do to treat these eye problems. AMD can be slowed in early to intermediate stages of dry AMD, high dose antioxidants, zinc, and you can buy these over the counter. I think one of them is Ocuvite. That's a drug I've seen in like Walgreens, CVS, and things like that. Also assisted devices, magnifiers, large print books, magazines, high intensity lighting, computers, tablets, e-readers, audiobooks, and podcast. And across the lifespan, depending on the cause, with congenital cataracts, maybe it was caused by maternal infection during gestation, or galactosemia, other metabolic disorders, genetic mutations, trauma, or very few cases of cataracts are related to rubella nowadays, can be often asymptomatic. How do you tell in a child if they would have cataracts? Probably the lack of reaction to bright lights, failure to notice toys or faces, or unexpected developmental delays. Testing is very similar to the adults, and surgery if vision is impaired is significant, and intraocular lenses may be implanted as well. And with pediatric glaucoma, 10% are diagnosed at birth, 80% diagnosed by age 1, and diagnosed after age 3, we call that juvenile glaucoma. Secondary congenital glaucoma causes all these different types of syndromes. Aniridia, neurofibromatosis. I'm not real familiar with those, but you can look those up and see what those consist of. Pediatric glaucoma is very difficult to diagnose. The child may show signs of photophobia, epiphora, puphthalmos, and bulbospasm. Treatment is trabeculotomy or goniotomy, also eye drops and oral medications. 80 to 90% promptly diagnosed, treated have near normal vision through life, so that's a good thing. We can get it treated without any long-term problems. And if you go back over these words, that second one, epiphora, that refers to a child who might have excessive watering of the eyes, and buphthalmos is enlargement of an eyeball. It is most commonly seen in infants and young children. It sometimes is referred to as the bupophthalmia. It usually appears in newborn period or the first 3 months of life. And this last word, blepharospasm, is just eye twitching. All right, and then and this trabeculotomy is more of just a surgical procedure that the doctor will remove part of that meshwork to allow a better flow of the aqueous humor, and may also remove adjacent structures. So kind of relieves that intraocular pressure when you're talking about glaucoma. And then juvenile macular degeneration is always a possibility. It is a different pathology from AMD. The types are Stargardt disease, most common type, Best disease, and juvenile retinoschistosis. And central vision loss, one eye may be more effective, no treatable or preventable type of treatments. And pregnant women glaucoma is relatively rare in women of childbearing age. Many medications for glaucoma have potential adverse effects on the fetus. Argon laser trabeculoplasty is relatively safe and only short-term benefits, adequate until woman has delivered the child. Older adults, you got to think about when they're prescribed eye drops that hand tremors will make it difficult to give themselves eye drops, and cognitive decline may cause forgetting to take the medication. Again, safety is a priority when we're talking about someone's eyesight, and we need to think about the aging patient who has at a potential to acquire any of these types of eye disorders. Okay, so again, observation and patient interview. Observe them with any difficulties they're having with vision. Know a little bit about their lifestyle with their history of smoking, diabetes, prescription drug use, and observe presence of cataracts if advanced, and assess family history of eye diseases and signs and symptoms of new rapid onset of age-related macular degeneration. Physical exam, testing general distance, near vision, testing periphery, testing on the Amsler grid, and examination for specific orders depending on patient sign and symptoms. These are some of the many nursing diagnoses that we may see with patients with eye disorders: decisional conflict, anxiety, fear, self-help management ineffective, and health maintenance ineffective, and definitely injury at risk for. And our probably primary goal is to keep our patients free from injury, be able to articulate understanding of reasons for and risk involved in treatment, and let them express their feelings about their diagnosis or how they unfortunately have reduced vision, and help them to participate in self-care activities to protect the eyes from further damage and maximize safety, and follow self-care instructions. Prevent injury, discuss adaptations at home, provide instructions related to vision loss, change in depth perception in hospital or care facility, notify housekeeping, and place sign on patient's door to alert personnel personnel not to change room arrangement because they're used to the way the furniture is arranged, so make sure all personnel know that. Promote wellness and teaching principles of self-care. Eye drops, are they able to perform activities of daily living? And what kind of applications with their lifestyle do patients need because of limitations? Maybe driving is something they shouldn't do anytime, or maybe just only at night. Facilitate orientation and environmental modifications. Again, orientation to the individual speaking in the environment, reduce anxiety. And these are just some other helpful hints about environmental modifications that you guys can read. Promote social wellness. Okay, note their coping mechanisms. Are they able to adapt them now at the present situation? And these are what we hope to provide. These are our outcomes. Remains free from injury, makes informed decisions about treatments, verbalizes concerns and identifies appropriate resources, verbalizes appropriate home care activities, and demonstrates correct medication administration, and list of the resources that are available in their community.